You're juggling it all: work, family, decisions, expectations, 6 hats, maybe more every single day. But behind the scenes, your body is running on stress, and stress left unchecked will lead to illness. I'm Dr. Shami, an integrated family doctor, and this is 6 Hats, the podcast that helps you understand what stress is doing to your body and what you can do about it now. Hello, everyone. Welcome back to the 6 Hats podcast. And today in this episode, we dive into the common issue of osteoarthritis. So I'm joined by physiotherapist Steffan Cavalera from Kieser in Melbourne. And we really want to dive deeper into osteoarthritis, what it is, how it's diagnosed, and why surgery isn't always the first step. And this is why I love to have this conversation. So we're also going to unpack the burden it has on the healthcare system and explore various options of treatment from management to surgical, and how Steffan uses a different approach when it comes to osteoarthritis. So welcome back, Steffan.
Hello, Shami. Thanks for having me back again.
Amazing. So, Steffan, I really enjoy our conversations about musculoskeletal conditions because, to be honest, I don't think as GPs we dive deep enough and we truly understand. So, very much like diagnosis, where do we go next? Often it's orthopedic surgeon or physio. And I would love to have a deeper conversation because, as you quite rightly said, there are so many options that really help the patient before we even think of surgery. But the first place I would love to start is, what exactly is arthritis? How do we even diagnose it?
Osteoarthritis is a disease which affects the whole joint. So the cartilage is probably the one everyone thinks of, but it also affects the subchondral bone, the synovium, the labrum in the hip, the meniscus in the knee, and all the surrounding tissues, soft tissues as well. In a typical healthy joint, there's an amount of degeneration and regeneration which occurs at the cartilage cells. In an osteoarthritic joint, there is more degeneration than regeneration. And you can think of cartilage like a sponge in a joint, absorbing and releasing fluid. And that fluid would be synovial fluid. And that acts to cushion and nourish the bones. And movement is really important because that's like squeezing and releasing the sponge. And it helps to refresh the fluid and maintain cartilage health.
Amazing. Now, so is everyone destined to have some degree of osteoarthritis as we age?
No, not everyone. Around a quarter of Australians will have osteoarthritis, and the most common are the hip and the knee. It is something that I think is more front of mind, whether we're picking that up more or we're living longer or we're sedentary. There's probably a combination of factors there.
Excellent. And when someone presents with it, is it mainly pain and swelling? So if I'm seeing it from my perspective, often the patient will come in saying knee pain, and it might be someone in their 40s, 50s, often older. So often is it pain that people complain about?
Yeah, I think that's the main driver. There's a few different clinical signs, the main one being pain with weight bearing. So whether that's standing, walking, going upstairs, but a couple of the other things would be morning stiffness, which typically relieves within an hour. And one of the other things we would find is a deficit in their range of movement. So for knees, for example, the inability to flex one knee as much as the other, or at the hip, the inability to flex their hip as much as the other. And often with that limitation, there is also pain.
Makes sense. So much sense. So this is where I want to go into the conversation. We always think, oh, got to go and see an orthopedic surgeon. You've got osteoarthritis. It showed up on x-rays. It's matching your examination as well. And, yes, we can think about physio. So that's where I want to go into. What can we do before we even think about surgery?
Well, I don't think you can make decisions on scans alone. So some people will have only a little bit of cartilage degeneration and they'll be experiencing quite significant symptoms. And then someone else might have quite significant degeneration and they've got really minimal symptoms because there's a number of other contributing factors. What's their general fitness like? What's their strength like? What's their body weight like? So if someone presents to me and all their clinical signs match up, we've done some testing. I personally always like to send them off for an x-ray to get a picture of what's going on and get their GP involved in that conversation. Before we think about, it's time to consult with the surgeon, let's see, can we start to address some of these other issues before we consider going under the knife?
Amazing. So let's go through all the different steps that you take. I loved how you mentioned, lifestyle factors as well. But yeah, let's dive deeper.
Well, I think it's important for this population to know that pain doesn't necessarily mean further damage. There is a bit of pain associated with osteoarthritis. That pain can be exacerbated because of the disease state. It can also be exacerbated by a lack of strength around the joint, a lack of general physical activity. So often when I see people, they've probably had pain going on for a little while, and naturally because of that, they've decreased their activity. They've avoided things. Maybe they've stopped gardening, they've stopped going up and down the stairs as much, and pain is a natural driver of that. But because of that, they become deconditioned in their muscles. There's that Pawnee saying, if you don't use it, you lose it. And that is very true, particularly for osteoarthritis. So we can delve a little bit deeper into how much they're currently doing, how much that's changed over the last few months. And has that changed because they're fearful that the pain they're getting is causing damage, or is the pain manageable? Is it a 2 out of 10, a 3 out of 10, but it resolves with a little bit of rest? I mean, ideally, I'd love everyone in no pain, but if it's a 2 or 3 out of 10 pain with a 20-minute walk, we're probably not going to get a consult with a surgeon. If it's really high pain with minimal activity, and that matches up with X-ray findings of minimal cartilage and they've already done everything they can, then yes, I'd probably say now's the time to catch up with a surgeon. But I think there's a lot more we can look at when people first present either to a GP or to a physiotherapist.
Amazing. So let's go through that steps, because as a physio, what steps would you first take?
I'd start with strength training. I think there are a number of benefits you can get for strength training, whether that is getting a bit of regeneration in the cartilage, if there is some cartilage there. So if it's absolute end stage OA and there's no cartilage, we're not going to be able to regenerate some of what was there previously. But if there is a bit of cartilage there with movement and exercise, we can actually generate a bit of cartilage through strength training and other activity. But I'd especially look at, okay, if it's knee osteoarthritis, can we strengthen up the quadriceps? Can we strengthen up the hamstrings, the calves, the muscles further up in the chain, the glutes? And if it's hip osteoarthritis, let's especially look at the hip muscles and then further down the chain. I think the barrier I come to there is, one, people's understanding of strength training, and then people's willingness to get into what I'd actually consider strength training. So walking isn't strength training. Strength training has to be challenging enough that we're able to fatigue the muscles and get that response of a strength adaptation. So for someone that comes in and says, look, I do 10 squats every day and I do some band exercises that a physio gave me years ago, I'd say, well, it's probably not challenging enough and it doesn't sound like it's been progressed at all. So you're not going to get any stronger from that. And then I talk about, okay, I think the end goal here is I'd want to get you lifting weights. Ultimately, that's the best way to get you stronger. Now, for this group that is potentially 60 plus years old, there's this misconception that going into the gym is bodybuilding and they need to wear tank tops and get huge, where it's just not the reality. The reality is we want them working hard so they can keep playing golf, keep walking, keep gardening, playing with grandchildren. It doesn't necessarily mean that we're going to be bulking up and doing it for aesthetics.
So it's so interesting. I want to explore those barriers. So when you mention strength training, so they've got this picture, it's not the environment they want to hang out in, it's too difficult. What other barriers do they come up with?
Well, there's probably also that they get pain with exercise and there's fear with that. And some of that fear is justified. Like if they go in and start lifting well above their capacity or pushing way into an uncomfortable range repeatedly, then that pain's not going to be good. But if it's a bit of pain just with general loading, similar to when they walk up the stairs, well, that's probably a necessary evil early stages. So we need to find out what their parameters are, what range we can start working within, and what intensity can they tolerate. So if I can challenge them enough that they're going to get a little bit stronger each week, then those parameters change over time. I can start to increase the range of movement that we work within. I can start to change the type of exercises we do. We can move from maybe exercises looking at just working one muscle group to more compound movements, things like leg press or weighted squat, and I can increase the intensity. And I think when I take someone through those initial stages, I am cautious because I want to make sure that I don't create too much of a pain response that they think I can't do this again. I'm causing damage or I'm too uncomfortable. So it can be a bit of a soft landing, but it also has to be challenging enough that we are getting progress.
And I want to mention why strength training is so important from the weight point of view. But from your point of view, when it comes to the joint, why is that so important? Is that to stabilize the joint and support it?
It's to support the joint. I use a very non-scientific explanation when I'm with patients. If you're standing, there's your passive structures, your joint and your ligament, and then your active structures, your muscles and your tendons. The more you're able to take up through your active structures, the more we can ease off the pressure from the passive structures. And I think that resonates with people a bit more than me going into the real detail of biomechanics and so forth. And it does make sense.
Absolutely. And I loved what you mentioned. It was so interesting. I was just having a conversation with a colleague today, and we just mentioned how her friends try and avoid strength training and the gym. And they just feel like if I can just eat well and stay slim, I don't need to do strength training. But strength training is so important for longevity, like what you said, supporting joints. But where I'm going to mention is actually how it's important to regulate weight and how we actually lose muscle mass from the age of 30. And that actually affects our hormones, and that's more likely to become insulin resistant. And so and we're going to go into it, how, weight has an impact on joints. And I often see this clinical picture of painful joints. Well, a couple of things may lead to that weight gain, but that actually affects the joint pain even more. And so we get caught up in this cycle. And what I love about strength training is it's not cardio. It's not like you've got to run. You don't have to cycle. You can actually do weights and lose weights and build strength, and you can start slow. You can go at your own pace. It's not about like hitting those heavy weights in the gym and watching what those people look like. It's your journey, and it's all about consistency, actually going every week, doing the weights. It's not about, wow, I need to get to this goal and that's it, I stop. It's actually consistency for the rest of your life, and that really promotes longevity in so many different ways. What are your thoughts on that, Stefan?
Yeah, that's exactly right. So I also have people ask me, particularly with osteoarthritis, how long do I have to do this for?
Yeah.
And my response is often, how long do you want to be playing golf for? How long do you want to be gardening for? Like, the reality is, as we age, we lose strength. We
Absolutely.
can't curb that completely, but we can slow down that rate. So if you are doing strength training, we can get an improvement short term, and we can make sure long term that you don't end up, I mean, like a lot of people that you would see 80 years old, unable to do basic activities, unable to take care of themselves. Whereas now we know there's people that are 80, 90 years old that are playing doubles tennis, that are going
Yeah.
for hikes. And I think, having social media now and even the news covering this a little bit more is a real positive to say, actually, you can do strength training, you can be really active into older age. And, going back to weight management, it's really important to know that most people that get joint replacement surgery at the hip and knee are in the pre-obese category. And
Wow.
apart from that, it is the obese one category. And I think there's 3 obese categories. So we're looking at people that are overweight having to get the surgery. And look, that's multifactorial, but a lot of that can be as well that they're reducing their physical activity because of the pain that they're getting in their joints, and they're shying away from strength training and building muscle.
Oh my God, it's just caught up in this wheel. I can just see it, like this catch 22, where you need to do it to actually get you feeling better, but the pain affects you. And then all of these lifestyle factors come in, and then the weight comes on. So you get caught up in a cycle. But the key thing is to start. And I literally just advised a patient the other week, type 2 diabetic, overweight. We're doing this for mainly to get that sugar regulated, but to actually see someone like yourself to guide him, because he's in his 60s and he hasn't exercised for years, and how that it's really important to get professional guidance, because you can hurt yourself if you suddenly decide to pick up weights and just do it at home. So I think that's such an important advice that you're giving, Stefan.
Yeah, and look, when it comes to doing things at home, doing things in a space, I think you can have 1 or 2 strategies at home, but predominantly people don't do big training programs at home long term.
Mm.
I think, we spoke about this for whether it's back pain or lateral hip pain, that you're actually better off going somewhere, challenging yourself, doing weights, getting guidance, whether it's with a physio, an exercise physiologist, or a personal trainer, an exercise scientist long term. But it is so important to have that stimulus of lifting weights and getting guidance with it. And, when we circle back to weight management, there's some really powerful statistics out there on how it can affect, particularly knee pain in people with osteoarthritis. So there was a study published in Arthritis and Rheumatism of overweight and obese adults with knee OA, and it found that losing around 1 kilogram, it was actually in pounds, it's an American study, but let's make it normalize it for Australians. Around 1 kilogram will actually result in more than 2 kilograms of pressure being removed from their
Wow.
knees. So
That
if
is
someone loses just 5 kilograms, it would relieve around 18 kilograms from pressure from their knees. So it's such an important factor for this group presenting with osteoarthritis.
And I love those numbers because it's so achievable. Like 1 kilogram is so achievable to see the impact it has. So if we could do a quick recap on like conservative management, what are the key areas, Stefan?
So first I'd have a look at how physically active they are. Okay. I'd want to promote movement as much as possible. And I'd want to educate them that, look, there is some pain with movement, but we want to make sure we're not completely avoiding walking to the shops, gardening. We might just set some parameters around, okay, well, if your pain is really shooting up after 10 minutes of walking, let's make sure that we keep you walking to 10-minute bouts initially until we strengthen you up a little bit more. Same with all their other activities. Then I would look at strength training and saying, okay, we need to start strength training and we need to make sure that we're doing it properly. It needs to be progressive in nature. It needs to be challenging. It needs to be reviewed over time, again, because the types of exercises and the intensity we can work at will change week by week. And if it's not progressive, then you're not going to get that long-term benefit. Then I would have a look at, what are the adjunct things? Maybe their diet can be looked at. Is it worth getting a dietitian or a nutritionist involved in this journey? What's their general health behaviors? Do they drink a lot, which would increase inflammation and affect their weight? Are they smokers again, which would increase inflammatory markers around their body and also have an effect on cartilage regeneration? So I'll have a look at those things and I'd want to get someone else involved. That's why I always like sending them for an X-ray. And with that, I say, look, let's get your GP involved. If I think they're at this stage where they're really limited in their mobility and they want an opinion from a surgeon, I would say, yes, okay, let's go consult with a surgeon. Or, for such a big decision like joint replacement surgery, why don't we get 2 surgical opinions? Because some surgeons might say, we can do surgery tomorrow, let's get started. Other surgeons might say, yes, you could get surgery, but you could probably get away with losing weight, strengthening around the joint, keeping active. And I think that's coming into the conversation a lot more because surgeons want really good outcomes for their patients. So they're not going to put someone in who's really obese, who has very little strength straight away. They'd rather get them fitter. And if they think that person can avoid it, then a lot of the time surgeon would say, like, you're okay, you can manage this conservatively for as long as possible.
Amazing. I love that you mentioned that. And I would love for you to share any patient stories of when they started their program. How long did they take to actually see pain reduction, see the benefits of strength training? What are we talking about? Are we talking weeks? Are we talking months?
I would say it takes around 6 weeks if you're training hard enough during that time period. If it's 6 weeks, but you're kind of doing a few home-based activities, squats and bands, you're probably not going to see a really significant change. If you're able to get guidance, go into a gym type environment, lift weights, and then get some of those changes around your lifestyle, then I think in 6 weeks you'll notice a difference. But it's important not to stop at 6 weeks. You can keep improving over time. And the reality is if someone has a 6 out of 10 pain with weight bearing in just incidental things throughout the day, it's going to take 3+ months until they get a real significant difference in their symptoms.
Makes sense. Makes sense. And I love the message about you've got to keep going. You can't stop. And I think I read somewhere like 2 weeks without that consistency, or 2 weeks of immobility results in muscle atrophy. So it doesn't take long for muscles to go the other way by not doing anything. So we've got to keep that consistency. I think the key message is to keep moving. And what we can talk about next is like surgery, what is involved, but we really want to focus on that conservative management. I loved what you said about getting different opinions, of just not jumping into surgery because there's so much you can do from lifestyle. But what would you say key messages are when someone's considering surgery?
I think it's more around your quality of life than it is around the scan. So if at the moment you're able to get through your usual activities, whether that be going into the shops, socializing with friends, if it's playing a sport like doubles tennis, if there's a bit of pain associated with that, but you're still able to do those activities, it's probably not the time right then to get surgery. That's probably the time to try and maximize what we can conservatively. But if we hit an endpoint and your symptoms are then worsening, that's then when you'd probably consider surgery a bit further. I know for me, clinically, what I look at, if someone's really stuck in their range of motion at the hip, so they really struggle with sitting, for example, then I'd probably say this is a good time because you're having to adjust the way you move, the way you sit, or it might even be affecting someone's work. At the knee, it's probably more around physical activity. I rarely see people who can't bend their knee more than 90 degrees. And 90 degrees is that kind of sitting position. So it's more around, are they able to go for their usual walk? But it's kind of an ongoing conversation. I think for most people, it's not one point like this is the perfect time to do surgery or this is exactly the time not to, which is why having a physio, a GP, and having surgeon in the conversation is really important. So you can gather everyone's advice and then make a decision. And if you're not sure, then continue with conservative.
Amazing. And before we let you go, I would love for you to share information about the programs that are available for osteoarthritic hips and knees and strength training.
Yeah, so there's a pretty famous study published called the GLAD. Do you know about that?
No, tell me more.
So GLAD is Good Life with Osteoarthritis Denmark. It's kind of a landmark study because of the amount of participants. It was 9,000 participants completed the program. Majority were diagnosed with knee OA and some had hip OA. The mean age of those people are around 65 years old, and their pain was between, on average, 4 to 5 out of 10, 10 being the worst pain they could have. So this looked at physiotherapy guided exercise over 6 weeks, twice a week, and a couple of education sessions. And it had really good results, particularly at the 3-month and 12-month follow-up in reductions of pain and improvements of function. I think some things that are missed from that study, because I know it's something that clients often talk to me about, is I've heard about the GLAD program and it is fantastic, especially if you haven't been doing something previously. But I mentioned before that there is a bit of a limitation with just body weight and band type exercises. It's a 6-week program. It encourages people to do things at home ongoing. In my opinion, it's not progressive enough in nature. It's not going to make a difference in 12 months' time if you've only done 6 weeks of exercise. So I think it's really important to take from that, okay, if you get moving, the research shows that if you strengthen, even if it's at a lower intensity, your symptoms will reduce for the most part. But we need to take that on to how do we make sure that 5 years down the track, we're also feeling good. That's when I think having a physio in your corner, having an exercise physiologist, even having a personal trainer in that journey and everyone kind of communicating together is really important. I'm very biased. So as part of my workplace, we have access to strength training equipment and we actually have programs for osteoarthritis. So we had a study done with one of the private health funds, I think it was 5 or so years ago, that had people that were candidates for hip and knee replacement. And we took them through a 3-month training program and we had amazing results from that. So reductions in pain, improvement in function, and even surgery avoidance. And the purpose isn't necessarily to avoid surgery because you might get surgery eventually. It's more around, can we improve that person's quality of life? And if they're going to get surgery, can we get better outcomes with surgery? But based on that pilot study, we now have programs where I think it's around the majority of private healthcare funds in Victoria will fund up to 3 months and over of gym membership at Kieser to get people moving and lifting weights. And then we then want those people to follow on and continue on doing strength training, especially in that environment where it can be progressive in nature, it can be monitored, it can be tailored. Because again, it's with strength training, it's not just one size fits all. It's not doing 10 squats at home and sticking to that or doing a band. It's okay, can we progress this appropriately over time so we can keep getting you stronger?
Amazing, amazing. Thank you so much for your time today, Steffan. Thanks for listening to Six Hats, where it's all about progress, not perfection. If this episode spoke to you, don't wait, hit follow now, leave a quick review, and share it with someone who needs to hear it. Want to take your next step today? Download my ebook. The link is waiting in the show notes. And remember, this is general advice only. Always speak to your practitioner for anything medical. See you next time.